and Pro-President NIMS University. Dr. N.P. Sunil sir, Principal, NIMS College. Dr. Naganandi ma'am, Professor and Head of the Department of Public Health and Dentistry. Dr. Rohit Sharma sir, Professor and Head of the Department of Oral Medicine and Radiology. Dr. Rohit Sharma sir, Professor and Head of the Department of Oral Pathology and Microbiology. Dr. Amit Sharma sir, Professor and Head of the Department of Oral and Maxillofacial Surgery. And I also welcome Dr. Shalini Jha and Dr. Deepak Chawla. Thank you sir, thank you ma'am. Now I would like to request our principal, Dr. N.K. Sunil sir, to kindly welcome our guest, Dr. Neelam Gada ma'am, tobacco de-addiction specialist and cosmetic dental surgeon. Now I would like to request our principal, Dr. N.K. Sunil sir, to kindly welcome our guest, Dr. Sunil Sharma sir, Dean and Director, NIMS College, Pro-President and NIMS College. So before starting the event, I would invite people to lighten the lamp of knowledge and wisdom. Let's start with the Saraswati Vandana. I request all the dignitaries to come forward to the event.
सर आप इधर थोड़ा साइड हो
हे शारदे माँ अज्ञानता से हमें तार दे माँ हे शारदे माँ अज्ञानता से हमें तार दे माँ तू स्वर की देवी ये संगीत तुझसे हर शब्द तेरा हर गीत तुझसे हम हैं अकेले हम हैं अधूरे तेरी शरण में हमें प्यार दे माँ हे शारदे माँ अज्ञानता से हमें तार दे माँ मुनियों ने समझी मुनियों ने जानी वेदों की भाषा पुराणों की वाणी हम भी तो समझे हम भी तो जाने विद्या का हमको अधिकार दे माँ हे शारदे माँ अज्ञानता से हमें तार दे माँ तू श्वेत वर्णी कमल पे विराजे हाथों में वीणा मुकुट सर पे साजे मन से हमारे मिटा दे अंधेरे हमको उजालों का संसार दे माँ हे शारदे माँ अज्ञानता से हमें तार
towards knowledge. Thank you everyone. Now after seeing the blessings, we shall begin with this program. To start the proceedings, I would like to invite our Honorable Principal Sir, Dr. M.K. Sunil, to deliver welcome address.
Very good morning to all. It's great, gives us immense pleasure and honor to welcome our chief guest, Dr. Sunil Sharma sir, the Pro Vice Chancellor of the NIMS University. Sir, I welcome you, sir, and thanks for the support giving continuously in organizing such a series of programs. And today's guest speaker, Dr. Neelam from Mumbai, who has been accepted an invitation and be a part of this tobacco deaddiction therapy. I welcome you, ma'am, on this August gathering, and thank you for accepting our invitation. And I welcome our 4 head of the departments who support continuously in organizing this particular CDE program on the tobacco addiction. So I welcome the Rohit Sharma, Professor and Head of the Department, Oral Medicine Radiology, Dr. Rohit Sharma, Professor and Head of Oral Pathology, and Dr. Amit Sharma, Professor and Head of Oral Surgery, and Dr. Namineni, Professor and Head of Community Dentistry. So these all of them have put in a lot of efforts in organizing this particular event. So I welcome all the head of the departments and other faculty members who supported for this event. And I think tobacco cessation is, everybody knows that how much importance. And definitely I think that today's speaker will enrich you about the various de-addiction therapy programs and the side effects and how you will prevention methods. And also I welcome Mr. Deepak from the Rotarian, who has been traveled and he is one of the co-member of this particular addiction therapy. So I welcome you on this program. Thank you. And also I welcome all the undergraduates and postgraduate students who have shown the enthusiastic participation in this program. Thank you.
Thank you so much, sir, for enlightening us with your kind and motivational words. Now, I would like to introduce our respected guest, Dr. Sunil Sharma, sir, Dean and Director, Institute College and Co-President of NIMS University, to share his expertise and knowledge.
Good morning. Principal Sahab, Dr. M.K. Sunil, invite this speaker, Dr. Neelam, and our team members, Dr. Rohit, Dr. Nandanani, another Rohit, Dr. Amit, senior faculty members, HODs, and dear students. On behalf of University, I welcome you all to this very important CDE program on tobacco cessation therapies. You know, the tobacco use is very rampant, particularly in this, we are situated in the rural setup. And if we talk about the use of tobacco, it's very rampant in this area, especially in villages. So our role in tobacco addiction or tobacco cessation is very important. For that purpose, the DCI has called every dental college to establish a tobacco cessation center. So in those lines, we also established our tobacco cessation center in this dental college, which is, I think, working actively. But I requested Principal Sahab to add one dental chair at that center and start oral cancer detection clinic at least for 2 days in a week. So as per the recent survey conducted in 2016, Madam, if I am wrong, please correct me, the prevalence of tobacco use is 42% in males, or it is more? Slightly more now. It is conducted in 2016, and about 28% in females. So the role of the dentist in tobacco cessation is very important. That is the purpose of dental council also. They started these tobacco cessation centers. So the dental surgeons are mainly they are involved in treatment of dental diseases, but we can contribute a lot for this tobacco cessation in this society, because we are the first person who examine the oral cavity. We can counsel the patient, we can guide him by the way of counseling or pharmacological therapies. So, purpose of this program conducting this CDE to make you aware the role of your role and to orient you, to train you, and to make you sensitize that you are very useful in tobacco cessation program. Okay. So with these words, I once again congratulate you for conducting this CDE program, and I assure you all my support in future CDE programs. With these words, I wish all the best for CDE.
Thank you, sir, for sharing your wisdom with us. Now it's time to express our gratitude. I kindly request our principal, Dr. L.K. sir, to kindly present this memento to our guest, Dr. Neelam Narayanan, tobacco de-addiction specialist and cosmetic dental research. Principal Dr. L.K. sir, to kindly present the memento to our guest Dr. Shri Sharma sir, Dean and Director of Dental College and Co-President. Head of the Department of Oral Medicine and Radiology, to come on the stage and read the vote of thanks.
Good morning, everyone. I am very much thankful to our professor who has given his valuable time for our CDE program. I am very much thankful to Dr. Neelam ma'am for giving us the opportunity to listen and understand the importance of tobacco de-addiction. I am very much thankful to our principal sir, whose motivation and encouragement for every time with us. Thank you to all the authorities, faculty members, my members in this program, Dr. Amit Kumar, Dr. Rohit Sharma, Dr. Nagini, and importantly my friend, Dr. Gaurav Chavda, and all the faculty, my PG students, in my faculty, Dr. Dabir Singh, Dr. Fajat, and last but importantly, our administrator, Harshal ji, he has done a lot of work for the CDE program, and thanks.
I request you to please present the memento to our principal sir. best with the kind and knowledgeable words. Thank you everyone for such a warm welcome. Before I actually start with the session, I would want to know from you that how and why do you feel this session is important? Anybody?
आप मूवमेंट का करेंगे, ठीक है, मूवमेंट का करेंगे ना, वो हटा देते हैं, इसको ना पकड़ करना है,
Yes,
सर, मूवमेंट करेंगे,
तो ये नहीं लगा।
वो क्या करेंगे, लाइट जाए,
Okay. Anybody else? So sorry. Okay, very nice. Very
much important creating such an enthusiasm in the students to get forward suggestion of this program.
fantastic. I am very happy with your holistic thought of having this session. Thank you very much. So, as sir said, there is a TCC center in the. First, tell me what are the postgraduate students for OMBR? Okay. PhD? Okay. Any other PG students? Okay. So I know who are going to answer the question, right? So, yeah, I know, I thought so. Yeah, should be okay. Put my PPT now. So yeah, TCC center is under which department? PhD or under OMBR? Okay. So who usually what is done at the TCC center until now? Somebody please rise and say. कोई जाता है वहाँ पे कि नहीं? Yes, please. Okay. So do you all prescribe NRTs or anything? Nicotine replacement therapies? Great, fantastic. So you all are already practicing to some extent. Everybody is aware 5A approach. You are an intern? Oh, nice. You know pretty well. So I would first like to call this as a sensitization and training program, because before I train you as dentists, as doctors, to help other people, I believe that this generation themselves, in spite of being doctors, are into some or the other form of tobacco. Yes? No? The innocent batch here. बाकी सब already कहीं पे हुक्का ले रहे हैं, ऐसा तो नहीं है, right? So basically, why is this session? As Sir said, there is a rampant spread of use of tobacco, and it is seen almost equally in males and females. In as young as children of age 8 and 10 have started picking up the habit. Previously, people when they turn 15, 18, 20, 21, they would feel the urge to start smoking. But now kids as young as 10 and 12 years of age have been getting into tobacco. As I mentioned, there has been no age or gender bar now. It is also equally seen in urban areas, rural slum pockets, etc. So that highlights the scope of our therapy towards tobacco cessation. Everywhere and anywhere, especially in our country, if you would go, you would always and often find patients who are in tobacco consumption. So I am Dr. Neelam Gada. I am a cosmetic dental surgeon practicing in Bombay since 12 years and also very extensively practice tobacco cessation therapies. Not only for my patients who come to my clinic, but now I have built up a practice where patients are referred by surgeons, cardiac surgeons, bariatric surgeons. Before they do surgeries on their patient, they would want that the patient should stop using or stop smoking, stop consuming tobacco in any form, so that the prognosis of their surgery is better. I am also the president for Rotary Club of Addiction Prevention, where our major focus is on addiction prevention or de-addiction therapies of tobacco, alcohol, drugs, digital de-addiction, in which we have interventions of training, preventive programs, community programs, etc. So why this session? Tobacco is really a big epidemic in India. Switch off this slide, I think. Tobacco is the single most and the largest preventable cause of disability and death in the world. The largest preventable cause of death. Tobacco kills more people each year than AIDS, fire, car accidents, suicides, murders and COVID all put together. Still, tobacco kills more people than these kind of causes of death. And unfortunately, tobacco is the only legal product or the consumer product which kills people when it is used as directed by the manufacturer. For example, for any consumer product, any food packet that we eat, they have to go through an approval of FSSAI. But in spite of knowing that tobacco causes a list of nasty diseases, it is still being sold, still being consumed. That high is the influence of tobacco companies or tobacco lobby in pushing their products into the market. So we all are aware any kind of food that is sold in the market has to go through approvals. But in spite of knowing that this causes cancer, this causes many other illnesses, this is still being sold. And India spends approximately 8,000 crore rupees for medical cost directly or indirectly related to tobacco. So unfortunately, India is the world's largest producer, consumer and exporter of unmanufactured tobacco. Out of 138 crore population in India, 27 crore people are involved into consumption of tobacco in some or the other form, out of which at least 10 crore die prematurely every year. So the statistics for consumption of tobacco is that usually 50% of the users, 50% of the users will die prematurely because of their tobacco consumption. 5,500 children start using tobacco every day. Start. That high is our scope to go and help people. 5,500 children in India start consuming some form of tobacco every day. And India contributes to 67% of global consumption of smokeless tobacco. tobacco consumption, as we all know, can be either smoking or smokeless, out of which the smokeless form, the gudka, manikchand, elaichi, etc., that out of the entire world we consume 67%, and hence we are also the global hub for oral cancers because of our high consumption of smokeless tobacco. But still, in private clinics, as we have seen, dental professionals do not act, right? Anybody who has experienced private practice as well, along with learning here, PGs, anybody who has done private practice and then come here. So in private practice, we usually see that tobacco cessation is not done as such. When I finished my internship and started my private practice, the only thing that I would usually tell somebody, some patient who would come out as a tobacco consumer, I would give those standard 3-4 lines. Like anybody who now sees patients at the university, how do you deal with patients? What do you usually counsel when you said we counsel them? Okay. So why usually the dental professionals don't act? One is they are too busy doing root canals, bridges, right? It's a lengthier procedure. They do not want to give time to the counseling, which usually takes approximately 45 minutes to 1 hour to take a history, to devise the plan and then talk about it. However, the major reason has been lack of expertise, and hence this session where you understand, gain knowledge and know the correct way of cessation therapies. There is no financial incentive. When you do an implant, how much you would maintain if you would do this, the same time that you would give, and hence for no financial incentive, dentists do not take interest in doing this. They themselves think that smokers or people who are consuming tobacco will not quit or cannot quit. How many of you all think so? None of you all. So until unless you have made someone quit, how did you get the confidence that they can quit? So PhD, PGs, how many of you all have actually gone through taken the counseling? How many of your patients have you seen? How many have quit? Any rough? Excellent. Help. So that is exactly where the expertise comes. When you learn how to manage that, only then you will believe that he or she can quit, or else we usually end up saying they will never be able to, they won't be able to. Thank you. Respect somebody, some dentists feel that they should respect patient's privacy. If it is his choice to smoke, who am I to tell him yes or no? And hence they do not talk about it. Negative message that if you start talking about tobacco, the patient will not come back for the implant. So instead do not talk, have the patient. Right. So these are few reasons. But as we often hear, has anybody come across anybody passing such comments? Are dentists really doctors? So I think this is the best chance to show that we actually can save lives. So tell me, suppose if there is a patient coming to you since last 3 months, you are doing multiple root canals, bridges, everything, full mouth kind of thing. From day one, you were aware that he or she is consuming tobacco or say smoking, but you never heard about it. Heavy smoker. In another, say 3-4 months or after a total of 6-7 months, you observe that there is a prevalent lesion or say stage 1 squamous cell carcinoma. Who is responsible for that? Patient? You? The patient is not responsible. Correct, we both are responsible. As a dental health professional, if you did not attend to that at the first visit or in the first month, and that is why the patient landed up in that situation, it is ethically wrong of what you did of not talking about it at all. But to talk, you need to be confident and well aware of all the facts. And that is what we will exactly do here. Before we go into the therapy part, let's have a little quick background of why people start using tobacco. Because when you actually, when you take a history of the patient, you should be aware why he is taking tobacco. Everybody has different reasons. What is the most common reason why people start smoking? That is the excuse that they give later. Exactly. Peer pressure. The research says that 90% of people who are into any kind of addiction, it starts with peers or friends. Who else would otherwise offer a cigarette, right? Parents, teachers, no. Relatives, no. Siblings, no. So 90% of the times, even if you were to ask an 80-year-old woman who is smoking since last 40 years, how did you start? 90% of the time the answer is peers or friends. However, the reason usually that the patient gives is stress. Now, although the patient would always feel it is because of stress that he is smoking and then it gives him a relief, I will today explain to you in detail that how it is actually smoking that causes stress and not because of stress, there is the smoking gives relief. And this knowledge is important for you to explain to the patient so he comes across, he clears up this myth that smoking helps to relieve stress. It is wrong. Smoking causes stress. Next common reason is constipation. Many patients, anybody who has come across patients telling for constipation reasons, very common. The second most common reason is constipation. So why I am going through these causes that if you were to help patient for tobacco cessation, you need to solve this problem as well. If you are not going to talk about this and if this has been the reason for him or her to consume tobacco, he is not going to be able to quit until unless you don't solve this problem. So it is important to know why the patient is consuming. So these are few previous reasons until many years it was a norm for men to do it, right? It was in all types of addiction. But gradually with gender equality and women empowerment, we try to equal up at all levels, and now the consumption previously used to be 80% men and 20% women. Now it is 55% men and 45% women. So after being obvious abstainers from consuming, we started thinking that why should we miss it out. In fact, in Kerala there is a Deaddiction Center only for women. That high is the demand. Why would they otherwise have this special place? Because that high is the consumption. Obviously, in teenagers who start, they start with this, looking cool, fashionable, dude kind of thing. Also, they follow idols. Media in any form has a very good, not good, but a high impression of what these celebrities do. As I already mentioned, tobacco lobby companies have played a major role since last 60 years in pushing tobacco products. Although it causes death and disability, they have played a very major role in pushing these products into the market. In very rural areas, when I used to go for camps, we have often come across this reason. In order to suppress hunger, the mother would give the child a little bit of tobacco so that nicotine in tobacco acts as an appetite suppressant. Also, the metabolism is increased. If you see chain smokers, usually they will be lean.
Because one, their diet pattern is disrupted, and also because it is an appetite suppressant. However, do not use it as a diet plan. To stay alert, every time that you get watchmen or truck drivers who usually drive at night also, always ask this history. Very often they are involved in tobacco consumption because it is a stimulant. It helps to keep them awake, alert at night, driving 8-10 hours at night. Sometimes, all the generations in the family are doing it. There are tobacco packets lying down in the house anywhere and everywhere. Even the grandfather is doing, the father is doing, the mother is doing, and then automatically it runs from generation to generation. So if you are talking to somebody who in whose family this is a very common thing, everybody has to be then roped in. That everybody needs to stop. You can't just tell that one person you stop and let those packets be lying around. Everybody is having it, but you have to stop. So you should know the reason how it started. Some people just because some bad event happened in their life, they tend to go towards these things just to do something bad. As I already mentioned, it is an appetite suppressant. As I said, these are the pictures of the packets of cigarette in which they were marketed previously. In fact, tobacco companies, when they finished enough pushing the product for men, they thought why not have the other 50% of population as well for their high targets of sale. That is why they made a range of products specifically for females, like long cigarette, slim cigarette, pink cigarette, low tar cigarette, mild cigarette. And then with these kind of advertisements, they try to show that the females can look cool or attractive because of smoking. But obviously there are repercussions. That's now not a very good diet plan to have. Also, it is used as a mystery. I don't know if you are aware of this word mystery, toothpaste pouch. Any such other words that is used in this part of the country? Reverse smoking is one way, yes. Manjan, okay. Any other words specifically heard in this? Kenny, okay. Anything else? So these are usually used by women to either clean their teeth. It is applied on the gums and the teeth usually in the morning, more often seen in females rather than males. Also, out of curiosity, nowadays the generation believes in YOLO. You only live once, and they want to try everything just for the sake of trying, no other agenda, just to feel how it feels to be high, and hence they want to try, and then they gradually get trapped into the addiction. And some people feel it helps to bond. Friends, because everybody is going, they also want to go. Anybody who has tried hookah? So everybody who is laughing, smiling, I can assume has tried. Okay. So tell me, anybody who thinks, this is a poll, so you have to raise a hand over yes or no. You can't stay silent or just can't give a giggle to me. Anybody who thinks hookah is a safer option to smoking cigarettes? Then why did you try? Why? Everybody says no. Anybody who thinks hookah is a safer option to cigarettes, please raise your hand. Everybody thinks hookah is equally harmful or more harmful? More harmful. Wow. So now you would tell me reasons why. Such a unanimous answer, I am so glad. So I am sure you must be knowing the reasons, right? But I agree, but my question is hookah more dangerous than cigarettes? Yes or no? Yes. Why? Contact is for longer time, very good. Usually hookah lounges when we go, we sit there for an hour, right? Correct. And a person who is usually smoking cigarette would take it for what, 10-15 minutes? Anybody? Who thinks? Okay, any other reason why hookahs are more dangerous than smoking cigarette? No filter, okay, but then there are few filters that are there, right? Anybody who knows how to make hookah with the no, we can ask kitne filter lagate hain na? You can sit here, right there, there is a space. Anybody who knows to make hookah, putting the flavor? Due to carbon monoxide, very good. There is always this one person in the group who knows how to make those rings. Anybody who knows? एक ग्रुप में एक बंदा तो रहता ही है ना जिसको रिंग बनाना आता है. Everybody is like, wow, ये कैसे हो रहा है? Okay, anyways, some other day we will see the ring. But how is hookah more dangerous? Anybody, any more reasons? So one good reason is that usually it is, in a hookah bar you would sit for an hour minimum. And when that happens, what you do is first hand smoking because you all are taking turns and you are consuming. But what happens is that there are other such 10 tables. And everybody smoke you are inhaling, that room which is usually closed, there is a lot of smoke that you are inhaling in a very short period of time. So what you are doing is second hand smoking. Inhaling air containing tobacco smoke is called second hand smoking. Second hand smoking itself causes 6 lakh deaths in a year in India. Usually it is the father who is smoking, the wife and the children are affected. Very often, initially the child would have repeated cold, cough, upper respiratory, throat infections, etc. And then gradually moves to asthma and then to other lung diseases. Very commonly seen. But there is something called as third hand smoking. Anybody? So invisible toxic brew of all the tobacco particles settles down everywhere around you. That is how, if you have smoked and you've gone home, your mom can come to know from your clothes, or there is a breath that is easily identified. Even if you would enter a room where someone has smoked 5 hours back, you would still get that smell or stink. That is because the tobacco particles are lying down everywhere. So when you go to hookah lounges, it is a classic example of first, second and third hand smoking happening together for a longer duration of time with a very large amount of smoke in that area, and hence hookahs are much more dangerous or hazardous than smoking cigarette. Clear? So anybody who wants to confess? Anyways, the reality is tobacco is the #1 killer in the world. At least one death happens every minute. By the time we finish this session, there will be at least 50-60 deaths that have happened across the world only because of tobacco. In India, 40% of health-related diseases occurs due to tobacco, and as I already mentioned, 50% of tobacco users will die early. So why people don't quit, and how do people go into this addiction? And as I had said that I will explain why tobacco causes stress. It is not stress which helps them, it is not that after consuming tobacco the stress is relieved. So what happens is, assume this red line to be a normal state of mind, like how you and me are at the moment. We are at a normal state of mind. This red line shows that when a person smokes, in approximately 8 to 10 seconds, the nicotine reaches the brain. When it reaches the brain, what happens is, there are nicotine receptors to which nicotine attaches, and there is a release of neurochemical called as dopamine. What happens when there is a release of dopamine? You feel good, you feel happy high. Yes. So the person has this momentary pleasure of feeling very good. So what he thinks that his stress is relieved. But what happens as nicotine metabolism happens, as it is flushed out, the state of mind goes from this momentary pleasure down. It does not stop now at the red line where there is a normal state of mind. There is a slight dip down. And hence after some time he will feel that anxiety, as if there is some stress. He is restless because he is now below the normal state of mind. And hence as that keeps increasing, the patient feels now I need to smoke again because now I am in stress. But how did the stress happen? Because this went up, whatever goes up comes down. But this doesn't stop here, and hence the patient goes in a little bit of stress. After which he takes the second cigarette, it makes him feel high, not as high as it was previously. So this is actually locked, somebody can again open it. So yeah. Got it. Yeah. So then the patient will have the second cigarette, again he will feel better. However, now the dip down is further down, below the red line. Then after some time the patient will have third cigarette. Again there is a dip down. Now he is in a lot of much more stressful situation than from that red line. And now the only way to come back to normal state of mind is by smoking cigarette. That is how the belief of the patient starts, that I am in stress and only smoking or consuming tobacco will help me to relieve stress. So as you see, now to reach a normal state of mind, he needs to smoke or he needs to take the smokeless form of tobacco. And that is how, this pattern is usually seen with any kind of addiction, be it tobacco, alcohol. First the person starts with say 1 beer, feels good. After a few days he thinks that, I need the second beer, then the third beer. Then together he wants 2 bottles minimum. Only then he will have that high. Otherwise he is not even having a high. He is just reaching a normal state of mind. And gradually it keeps increasing, and now he needs 3 bottles of beer to feel high. Until 2.5 bottles, nothing happens. He is normal. So what do we usually say? कि इसका capacity बहुत ज़्यादा है. 3 में तो इसको कुछ भी नहीं होता. But what is actually happening? He is getting trapped into the addiction, from which now coming back will be really difficult. Because if he won't have, either he will be in stress, and sometimes to the extent that now to stay at a normal state of mind also they need to smoke. That is how they get trapped into these shackles. And that is how they start believing, I have stress, that is why I need. But it is actually smoking that puts them down into the stressful situation, and then to stay normal they feel this is the only way out. So how many people will get addicted? Not everybody gets addicted, right? There is always this one story which patient gives. I know that auntie, I know that uncle, he is smoking since 40 years. Unko kuch nahi hua. So not everybody gets addicted. However, which is the most addictive form of substance abuse out of tobacco, alcohol, heroin, cocaine, and all the drugs that you are aware of? Which is the most addictive substance? It is tobacco. Although people feel more dangerous is drugs, more addictive is drugs, but that is not true. Tobacco is something which is the most addictive substance, which means that for every 3 people who try, 1 will get severely addicted. That high. It is most difficult to de-addict a patient who is into tobacco addiction than a person who is into cocaine or alcohol. Because the addictive power of nicotine is really very high. So if you see, for every 3 people who try, 1 of them will get severely addicted. For example, in alcohol, for every 8 people who try, only 1 will get addicted. That much is the difference. and hence because of its high addictive power, patients really feel that they will never be able to the extent that many doctors feel that this is not something which is ever going to work, he will have to stay in that state of mind. For example, the awareness of tobacco hazards is so high that even the rural most area in Jaipur, wherever they are consuming tobacco in any form, are aware that tobacco causes cancer, that it is bad for health. They themselves must have seen people around them who must have had some form of cancer because of tobacco, but they still continue to consume. Can you feel the helplessness of that person? That knowing that this is going, not everybody wants to die, right? Although there are few patients who say, what excuse they give? मरना ही तो है. मैंने मेरी जिंदगी बहुत देख ली है वैसे टाइप. But the truth is, not everybody wants to die. So if I were to present, put a plate of poison, would anybody take it? No. But at the same place, if this person who knows tobacco causes cancer, smoking causes, is actually not willing, but is smoking at least 10-20 cigarettes a day, consuming say 10 packets of vodka every day, knowing. Survey shows 96% of the people who are consuming tobacco are well aware that it is bad for health. There has been enough awareness, not only through the medical camps that we do, through what we talk, but on the packet itself it now comes, right? Do you think of any other product on which there is a pictorial warning put up that this causes cancer, you can still consume it? Is there any other product? No. So that I am trying to show you the bigger picture of how advertisement companies have invested in this. It is still being sold. The person who is consuming knows it causes cancer, but is still consuming it. And there is some role that we can play between these cycles. So that is the addictive power. Coming to types, we all know smoking and smokeless forms. Snuffing, inhaling, chewing, dipping, stuffing are the different ways. These are the different names in which it is sold in different parts of the country, either mixed with something like slake lime, which increases the absorption of nicotine, or sometimes adding erica nut, which itself is carcinogenic. And zarda, kimam, mawa, kheni, gudka, pan, these are the different names, but however the tobacco content remains. There are few products which shows there is no tobacco. Does anybody know brand names? Yeah? Pan Parag? Pan Masala? Rajnigandha? So most of them, do you know that most of them claim? What? I didn't hear. Vimal Pan Masala. Okay, I thought you were singing the jingle. Anyways, so these are the different names by which it is sold. Under the smoking forms, so these are the different ways, some of them also inhale. But yeah, unfortunately this is a very big figure. 67% consumption of smokeless tobacco is usually an idea of our country, because we produce tobacco leaves which are then dried, chopped, powdered and used, and that is why unfortunately 67% of global consumption of smokeless tobacco is in India. These are the smoking forms, different names: bidi, cigarette, cigars, sutta, hookah, chillam, dhumti, cherut and pipe. But these are the new systems. Anybody aware about e-cigarettes? Anybody tried, seen? Vapes, yeah, vapes. Anybody who has seen? ट्राई तो तुम लोग ने किया नहीं होगा तो देखा तो है ना. Anybody who has tried, with so much of people talking, somebody would say a yes. Anybody tried? And everybody feels it is but they have a recording. So anybody who has tried, yeah. Nobody has tried and nobody feels it is a safer option, right? Everybody is well knowledge, well. Anybody knows what is the difference between e-cigarettes and vapes? Yes, nicotine what? Nicotine content. No. So nicotine content is usually not a measurable thing. It is tobacco which is good. Nicotine is just a part of it. You can't separate the nicotine from the tobacco. Yeah. So anybody who knows the difference? In this whole e-cigarette, where is the nicotine? Or where is the tobacco, I should say? Where is the tobacco? So again, electronic nicotine delivery systems or vapes or e-cigarettes were actually a advertisement gimmick by the companies to push this product for the younger generation. Easy to carry, bar jaake cigarette, going to the pan wala and buying cigarettes might not be a doable thing. So just buy once and keep it. The difference between e-cigarettes and vapes are both have liquefied tobacco. It is in a liquid form. Both have flavors. The combustion is not by fire the way we do in cigarettes. However, it is by a battery. And hence the amount of carbon monoxide is more. In one of them, the batteries are rechargeable. One of them is a one-time use. In one of them, you can keep changing flavors. In the other one, you can't change flavors. That is the only difference. However, when it comes to tobacco, there are actually 4,000 chemicals in a cigarette, out of which 200 are poisonous. Around 60 to 70 of them are carcinogenic. But there is only one product which is addictive, and that is nicotine. So when I talk about poisonous chemicals, it usually has arsenic, acetic acid, acetone, ammonia, benzene, cadmium, carbon monoxide, hydrazine, formaldehyde, naphthalene, nickel and polonium. However, it is the nicotine part which makes it more addictive, but it is these chemicals that causes other many nasty illnesses. So quickly going to hazards, we already know physical hazards, cancer, more than 60-70 types of cancers are seen. These are some pre-malignant, malignant lesions, post-treatment, pre-malignant lesions. However, all of them know that it causes cancer. Patients do not know that it actually affects each and every part of the body. Right from heart attacks to brain stroke, paralysis. Because what tobacco does is it causes thickening of the blood. There are blood clot formation and it goes and clogs the arteries either in the heart or in the brain, then causing paralysis or stroke. So for patients who give you this excuse that, I have lived enough now. So ask him, but are you willing to, if you were to get paralysis, you are okay to be bedridden for another 10 years, 15 years. It's not that tobacco is such poisonous. It is a slow poison. Whether it comes with cancer or whether it comes with paralysis or heart attack, it takes everything down the drain. Many lung diseases because of the smoking forms. Dental problems we all know. Males, infertility in males very often seen in today's generation where they come up with issues, both male and female, for conceiving. There is a very high rise in the number of couples going for IVF or other treatments. And if you were to ask them their history of consumption of tobacco, it is usually high. So it reduces the sperm count, sperm mobility, sperm lifespan, and hence in general harms the sexuality and the fertility. Similarly, for maternity health, although obviously the moms, the pregnant women will not smoke that time, but the previously smoked has an impact on their reproductive system. And hence what is often seen as low birth weight, decreased fetal growth, spontaneous abortions, fetal death, ectopic pregnancy, vaginal bleeding, placental abruption, birth defects, and increased nicotine receptors in baby's brain. Damage in the womb is also seen, stillborn, spontaneous miscarriages, premature babies are born with genetic defects. So what is the government and WHO doing? In the last budget, as we see, there is every time a raise in the tax on cigarettes. There are many other rules and many of these itself are not being followed. For example, in few states, you cannot sell a cigarette packet loose. each cigarette cannot be sold loose. Reason being, anybody can think why it would be like that? Somebody rise and please answer. You can only buy the whole packet, you cannot buy a single cigarette. Yes? Okay, maybe, but that's not the answer. Yes? Exactly, to keep it expensive so that the children cannot afford buying the whole packet. And sometimes the children don't know how to hide, where to hide, so they just take one cigarette and then finish it off, then go home. So there are many other, there is a Cigarette and Other Tobacco Product Act which was passed in 2003, for which there will be a raise in tax every time on tobacco products, ban on the advertisements. Now whatever advertisements we see, that is more of a surrogate advertisements. They claim that there is no tobacco in it. Then I don't know what are they trying to show if there is no tobacco. And ban in smoking in public places, again not followed in many places. Actors, they usually give a disclaimer if they are showing any tobacco products for at least 20 seconds, the disclaimer should be seen. Restriction on the content, size and number at point of sale. For example, the panwala who sells is not supposed to advertise or keep in display any of the tobacco products. But that is what is not followed usually. Pictorial health warning on tobacco products. Previously it used to be 60% when the act came. That time it was 60% of the packet should be covered with the pictorial warning, which is now almost 90%. 80 to 90% of the package should be covered with these kind of warnings and what all it causes. So it is not only cancer, but many other lung disease and other illnesses that I mentioned. So this is the act. But why people don't quit? Already as I mentioned, the nicotine addictive power is really high, but also because it is a little complex disease. It is not only about nicotine and the bar graph that I showed. What happens is, it has a very psychological effect as well. It is not only the nicotine. For example, many patients, they feel that I would like to smoke when I am with this friend. I like to smoke when I leave from the office, when I leave from work. That time, that graph doesn't work. So although the physical effects of nicotine are there is a psychological effect as well, and also there is an environmental factor as to who would smoke when, how. Sometimes it is related to a person or a place or a thing or an event, and hence it is multifaceted, complex problem that involves different things like the human nature, the nature of that person, obviously the addictive power, the immunity of that patient, the environmental factors, how he is usually working in his life, etc. I will show that later. So why to quit? Reasons that you and me think that health reasons would be our priority to advise or to offer to the patient, but not everybody would have that as their priority, at the number one of their priority list. For someone, the person wants to quit because he doesn't want the second-hand smoking to go on to his child, to his newborn child, and hence he wants to quit. For him, tobacco causes cancer is not important for him. So every time the reasons why they want to quit are different, why they started is different. So when you take history, it has to be really long, in depth. You have to let the patient talk as much as possible. So these are the different reasons you can give them. They will be healthy, family will be healthy, life expectancy, quality of life. Obviously for some people, if you would actually calculate for them how much they have been spending each day or each month or each year, it comes to a really big figure. Because buying 10-20 packets of gutka, manikchand or pan masala is sometimes not in the affordable range of that person, but he still keeps buying them. We see articles in the newspaper for alcohol and other addictions where they go and actually, kill someone just for one bottle of beer. So that is the addictive power of this. So peaceful environment at home, the probability of the child getting involved reduces drastically. So when to quit? For any patient, theoretically, obviously, when to quit, the best day was the day you started. But if you were to advise to any patient, you should always say now. It's a simple one-line answer that you should quit now. Advantages after quitting, fortunately, the benefits start almost within 20 minutes. There is a sudden betterment in blood pressure, the pulse, the carbon dioxide levels in the body, and that way the probability of getting lung cancer, heart attacks, everything reduces gradually. In general, that patient will be having few other issues. For example, if he is consuming BP medicines, you can always connect that to the tobacco consumption, and make him understand how it will be better for his health. So giving them relevant reasons are going to be very important. We will talk about some myths, some excuses that patients give, that I will cut it to half, but I cannot quit completely. ठीक है ना, something is better than nothing. 10 cigarette के बदले 5 cigarette will do less harm. Will you allow that patient, or what will you advise? But he says, I can't quit completely. I will try to reduce because today you have consulted me, given me advice. NRT can be given, but why this is wrong? So what happens? Oh, sorry. So usually people who say, I have tried to cut it to half, or I will only be able to cut it to half the consumption, such people, they tend to puff a little longer in order to compensate for the reduced number of cigarettes. For people who are into smokeless tobacco, they will tend to chew instead of half an hour, they will keep chewing for at least 1 hour. So we are not doing any good for them. And hence, when it comes to quitting, the best way is cold turkey method. When I say cold turkey, which means quitting all at once. Even if they are consuming say 10 cigarettes, the best way is to come down to 0 directly. This is theoretical, but that's not what happens practically. None of the patients are usually ready until and unless something has changed for them and they are like, no, I have to quit. But otherwise, most of the patients will try to bargain with you that I'll gradually taper it down and then I'll quit. However, theoretically, you should know what is the best method. It is quitting all at once, which is called the cold turkey method. I have switched to mild, light, filter or low tar cigarettes. Excuses by the patient. So irrespective of whatever, whether it is mild, light, again, this is also one way of, it is like an advertisement giving again, the marketing strategy of these companies, as the world started shifting to healthier options, to better fitness levels, they also presented a healthier option. Okay, we have these herbal cigarettes. Anybody thinks herbal cigarette is a real thing? Herbal hookah is a real herbal thing. I had a cousin who said, I am having herbal. It has nothing to do with the lecture that you are giving. So ideally, the tobacco content in none of these reduces. Just by adding a filter, what gives is a smoother drag. You all understand? Smoother drag, obviously. So until and unless there is no tobacco, there is no nicotine, and that high is not felt, why will the patient consume it? Then it will be as long as just puffing some rasna syrup or something. There is just flavor, there is no tobacco, there is no high, but that is not what they are looking for. So remember that if at all you are having a bit of a kick or a high, there has to be tobacco. So putting filters or anything doesn't matter. The tobacco content remains the same. You should know this so that when a patient comes to you with this excuse, you can explain it to them. This again, very common thing. Okay, since 80 years, an 80-year-old will tell 40-45 years I have been smoking. Or somebody younger gives an example of this granny very often. Then you should explain to them that everybody is having a different genetic component, and every third person who consumes tobacco will die prematurely through a range of difficult diseases that we already discussed. The addictive power is really high, and the number of people who will get addicted is also very high. It is very difficult to come out of it. Not everybody will have the same process. So some people who are having smokeless tobacco try to argue that I don't inhale or I don't take it inside, I just chew and spit it out. Right? Very commonly heard. So obviously one of the reasons we as dentists know that the oral mucosa is anyways going to keep absorbing everything that the patient is chewing. But other than that, there is one fact that I would like to highlight here, that tobacco farms are never fenced. There is no cattle, no bird who consumes on tobacco leaves. There is no scarecrow. Nobody consumes tobacco leaves. So I believe that this is nature's way of telling us that this is not meant for consumption. In fact, even those laborers who roll tobacco leaves to make BDs, they themselves, just by touching tobacco leaves often, they have something called as green sickness syndrome. What happens is they have certain side effects like nausea, vomiting, gastric upset, skin rashes, etc. just by rolling tobacco leaves. That high is the absorption. And obviously, again, the amount of time usually the smokeless tobacco is taken is much higher than the smoking forms. So how do we fight this? So what do you think is, what are the components that should be there when you are treating a patient, when you want the tobacco cessation to be successful? What do you think should be there in the whole system? Motivate that person, very good. So usually what people believe that the patient should have that willpower. For people who do not or cannot quit, they are pretty often nagged by other people. Sirf willpower hi chahiye, you can do it. That is how they try to motivate. But that is not the only thing which is required. Along with the willpower, there has to be a continued motivation. Because the addictive power is so high, that should be equal, there should equally be a high amount of motivation that goes in de-addicting the patient. And there has to be a commitment of continuous follow-up. It is not an overnight miracle to be expected that, as you do the motivation and tomorrow the patient will be good to go. That whole cycle, the mechanism that has been going in the brain for so many days or years or months has to be reversed back. It's a brain disease. So behavior change is what we are expecting from the patient when we try to counsel them or motivate them to de-addict. So there are different cases in which we need behavior change. For example, which treatment plans do you think oral hygiene instructions are very important? After which treatment plans, which dental treatment plans do you give oral hygiene instructions? Scaling, okay. Root canals, do you give? Implants, RPD, extraction, yes. So not giving proper instructions can actually make a lot of difference. So for example, suppose you have done implants. You did not give the oral hygiene instructions. The implant fails because of bad hygiene in say 2 years. Who is responsible? Will the dentist pay for the second, if it has to be removed and placed a new implant? No. But where was the difference? Only in giving proper instructions to the patient so that the behavior changes. What we need over here when we are talking about tobacco cessation is a change in behavior. For all kind of addictions, we have to first assess in which stage the patient is, in which stage of behavior. It can be pre-contemplation, contemplation, determination, action, maintenance or relapse. I will take each of these stages and make you understand that if the patient is in this stage, what you have to actually do. Each of the stages have different kind of interventions that you will take up with the patient. Starting with pre-contemplation, these are usually happy users, completely in denial that there is a problem. Tobacco से कुछ नहीं होता, आप जाने दो, ये सब बातें छोड़ दो. We don't need to quit tobacco. मेरी दादी है 40 साल से ले रही है, उनको कुछ नहीं हुआ. that kind of an attitude where they do not consider that it is a problem. In such cases, so this is a stage of denial. In such cases, you cannot be motivating them. Nahi, chhod do, chhod do, chhod do. They don't understand the problem. You just give them the facts, the benefits of quitting, the hazards of consuming, why it is important to quit. Obviously, when you talk, it has to be, your instructions to them should be strong and personalized. The relevant benefits, the relevant reasons should be given to this patient. Giving them NRT is not going to help because they do not understand the problem. They are nowhere looking at a solution. So here in this stage of pre-contemplation, they don't accept that there is a problem, and hence there is no scope of giving them solutions. You can only give them facts about the cessation. Second stage is contemplation. In this, the patient realizes that there is a problem, but is not willing to work towards the solution. There is always an excuse or a but that, I know I have to quit, I know it is bad, but I don't think I can quit. But maybe someday later, maybe I will quit whenever I want to, I can do it later. That kind of excuses are there. So in this stage, the patient realizes that there is a problem, but does not want to work towards the solution. This is the contemplation stage. He is in an ambivalent stage, a stage of confusion, stage of doubt. He thinks it is bad for health, but how to quit, should I quit, can I quit, those kind of questions are there. What will be your role is to shift them from this confusion, from this doubt of whether I can quit, yes you can. Is it important to quit? Yes you can, you have to. So you have to remove them, they are weighing whether they should quit or they should not quit. There is an excuse, there is still a slight urge to quit, but they are not shifting, that shift of okay, I will quit. And hence what is required here is your motivation for them to quit. This is so in these cases what you will mainly do is motivation, but remember it is always the patient's choice and responsibility, and depending upon their efficiency that they will change. You don't have to push them, you have to motivate them. Next is the preparation stage. In this stage the patient is motivated enough and has decided to quit. He has not quit yet. There are some patients who come directly to you in the preparation stage. Okay, I want to quit now. Or suppose if you explain to them, okay, you have a prevalent lesion, he will tell you, okay, I want to quit. So this patient is motivated enough, he is ready to quit, he has not yet quit, but he is finding out how will I be able to quit. So here you will give them solutions. Here the motivation is already there, what is needed is the solution part. So he is ready to make that change. That anxiety might be there, that will I be able to quit, or the withdrawal symptoms will be there. But he is motivated enough. Here you have to give them proper solutions, menu of options of treatment, and give them the professional advice, evaluate the ability, and negotiate the best treatment plan. Yes. Give me 15 minutes. Yeah. After this, I will take a small quiz and then break. So, in this stage, many patients come to you in this stage, or you motivate some patients and push them in this stage. What do you have to do when the patient is motivated? Initially, this is like a star formula, is how I say, set a quit date. So ideally, theoretically, when should be the quit date? Now. But patients don't agree like this, the way you guys are agreeing to me. But you have to negotiate. Very important thing before I teach you what to talk, how to talk. Remember, the treatment plan in tobacco cessation is always customized, is as per the patient. As a dentist, we have become very prescriptive in nature, right? Authoritative. मैंने बोला root canal तो root canal ही. No filling. I said this means यही होगा, which is okay because you have that expertise. But in case of tobacco cessation, the patient knows his body better. what is needed is that psychological willpower as well. And hence it is not only your expertise and advice that is needed. Else everybody would, it cannot be a standard treatment for everybody. Each patient is different, causes are different, their ability to deal with the withdrawal is different. And hence everything that we discuss has to be as per the patient. As I told you, ideally it is quit at once, quit now. But if the patient says, no, I will taper, you will allow them to taper. Usually when the quit date, when I set a quit date, average they say it should not be more than 2 weeks away. But the best way to calculate is depending upon how many number of cigarettes they are having or number of packets that they are having. If they are having 10 cigarettes a day, tell them the quit date should be 10 days away. If they are having 15 packets a day, the quit date should be set not more than 15 days away. Otherwise the whole motivation can get diluted. So that way you also give them a chance to taper one at a time, which feels very comfortable for the patient. So that is how you set the quit date. Setting a quit date is really as important as how we do goal setting in life and everything. Okay. Tell your close people. T is tell your close people. Close people means family and friends. Why do we need to tell the family? They will help you. Very good. How? Reminding you, yes, to have that accountability that you have decided to quit, now do not go into it. You know that watch can be kept by the family, but there is one more reason. Yeah, that is accountability we spoke. Anything else was some, emotional support, very good. The patient is going to go through a lot of withdrawal symptoms immediately when he quits. And those withdrawal symptoms will be mainly irritability, restlessness, anxiety, aggressive behavior. Who is going to take all this irritation? Usually the family. Withdrawal symptoms are bound to be there, and hence it is very important to make them aware, the patient himself and the family, that the withdrawal symptoms will be these, and that is how it is going to be possible to quit. It is a stage, it is a phase that the patient has to go through and help him to manage for some time. Tell your friends, family and friends. Why tell friends? Somebody rise and say, I can't hear well. Exactly, very good. As we started with that, it is 90% of times because of peer pressure that people get into this. It is mainly with friends that people go and smoke. So it is very important to tell them that I have decided to quit, and hence please do not offer me this from henceforth. Then is A, very important. Anticipate challenges, withdrawal symptoms, cravings, and the trigger factors. And how will they cope up with that? The first two, S and T, there are many patients who do it themselves. When they decide to quit, 50% of patients who come to me have already had 1 or 2 attempts in the past, in which they did setting the quit date, they told the family friends. But why they usually fail, or as she mentioned, that what happens, that when withdrawal symptoms come up, they cannot manage and then they do not quit. This is the major part where we as health professionals can make a difference. Managing their withdrawal symptoms, cravings and trigger factors have to be discussed prior. If you don't discuss the withdrawal symptoms in the same consultation that you did, what happens is the patient tries to quit as per the set quit date, he told his family and friends, but what happens from day 1, day 2, day 3, there are withdrawal symptoms. Most common withdrawal symptoms are anxiety, aggressive behavior, irritability, restless. The patient is not aware that these are withdrawal symptoms. What will he feel? That something is wrong with my body. As soon as I quit, these anxiety attacks came to me. And in such cases, the patient comes to a permanent belief that if I quit, something wrong will happen to my body, and hence my body is now not meant for quitting. This is the thought process of many people who have quit in the past. And hence it is your responsibility to change that belief that you can quit. Withdrawal symptoms are a part of quitting. It will be there for this certain time and you will help them to manage those withdrawal symptoms. Only then they will be able to take it forward. Similarly, I will talk withdrawal symptoms and cravings, but here the point that I am trying to make is you have to talk to them about withdrawal symptoms and cravings in the first consultation only, that this is what is going. When somebody is aware of what is going to happen, it is easier to deal with it, rather than it coming as a surprise and he is unaware what is happening to me. And R is remove cues, by which I mean remove all the ashtray, hookah flavors, coal, the pot and everything, all such things, lighters or the packets of manikchand, gutka, whatever they are consuming has to be removed from their environment and throw them. They act as a very big trigger factor to go to relapse. So tell them to do this. You have to reinforce, rearrange, follow up, and also relapse should be spoken about. Because of the high addictive power of nicotine, relapse is a very common thing in tobacco cessation. It is not to be considered as a failure, it is a part of the journey. Relapse does happen. Make the patient aware that there is always a chance that you might go into relapse, but we can again keep trying. We can probably the withdrawal symptoms you didn't manage well, the cravings you didn't manage well for him, and hence he went into relapse. So we can always try different things. As I mentioned, it is a tailor-made intervention for everybody. Maybe the tailoring that you did for this patient was not perfectly in alignment for what he needs. So again, everything can be spoken of, and the patient has to be put again into a preparation stage and do this star again. Next, so keep a, I'll talk about these options later. So fourth stage, after pre-contemplation, contemplation, preparation, the fourth stage in which he will act, he will quit. This stage starts from day 0 of quitting. When I say quit, means he is not consuming a single cigarette or a single packet. What happened is that in preparation stage he was tapering, he was motivated, but now he is actually acting upon it. So right from day 0 to 6 months, the patient is said to be in an action stage. In action stage, what is your role? Follow up. And under follow up, what will you actually do? Always acknowledge and appreciate the patient. For even if he has quit for 3 days and went into relapse, you will first appreciate him for those 3 days of cessation. Because you and I now realize that it is a very difficult process to come out of it. Any attempts or efforts taken in being able to quit should be appreciated. Then ask about the difficulties that he faced. For some patients, the withdrawal symptom can be only headache, but you counsel them for anxiety, aggressive behavior. So if in the follow-up you realize that the difficulty faced for withdrawal was headache, what will you do? Take care of his headache part, give him medication for that. That if at all you have a headache, this is what you will do. So ask them about, did you have cravings? How did you manage them? Did you do as I said, or did you do something else? Sometimes the patient has their own ways of managing themselves. They know their body better. So ask about that whole 1 week, what happened in the aspect of cessation. There might be a need to change something. There might be something new that has cropped up. Or maybe a rarer withdrawal symptom was seen in him rather than the common ones that you discussed. So follow-up is required and all these details are to be taken, but foremost you will appreciate him for the number of days he has been able to quit. So that is about action stage. Depending upon first we will only do counseling, we do not give NRT on day 1 of the consultation. You might need to put or add NRT when there is a follow-up if the patient is finding it very difficult to manage the cravings. The 5th stage is maintenance stage. Patients from 6 months onward, when they have abstained from any use of tobacco, from 6 months to 2 years, the patient is said to be in maintenance stage. It has been more than 6 months, he has been away. In this stage, usually just a talk about, there might be different ways to deal with the patient. The cravings are differently attended. This is what you will do in the maintenance stage. Support their lifestyle. Sometimes there is a need to change this behavior through a lifestyle change. And also keep on acknowledging, appreciating the patient for what he has done. Something happened and patient goes back to his previous pattern. It's called a relapse. As I already mentioned, relapse in tobacco cessation is a very common thing. You need to talk about relapse on day 1 itself. That if by any chance you go into relapse, we can again try it. What you will do when the patient is in relapse? In relapse, patient can then go back in any stage. He can again go back telling you, nahi, chhodne ki zarurat nahi hai. It's okay. He will say, nahi, it's not possible only to quit, let it go. So patient can also go in a motivation stage. Okay, I went, I did smoke again, but now I am willing to quit again. So this is how he can go back into the preparation stage. Sometimes the patient has put himself into action stage again. So now again you have to see back in which stage he has come to you and manage it accordingly. So relapse is not a failure, patient re-enters the change cycle and you again find why he went into relapse, what made him go back into the relapse, and then deal accordingly. There is a term called as slip. Slip means the patient did not go back to his previous pattern. Only it's a one-off event. It was my birthday. Even if the patient is in maintenance stage, he will be like, I just had this one time. I just want to have it one time. It is my birthday today. I had my results today. So just that one-off is called a slip. It is not relapse. Relapse is usually going back in that previous pattern of consuming 2, 3, 10, 20 in a day. One-off is called a slip. In that case, you have to explain to the patient that this can be that trap from which you can actually go into relapse. If you had a slip, it is okay, I understand. But please take care that you do not get into such slips because they are the biggest trap points to go back into relapse or the previous cycle. So there is a difference between slip and relapse. So pre-contemplation, patient is in denial stage. He says there is no problem, no need of solution. Contemplation, he says maybe, ambivalent stage, confusion stage, there is always an excuse. In determination or preparation stage, he is now motivated, let's go and quit. In action stage, he starts quitting. Until 6 months, he is supposed to be called in action stage. Over 6 months, he is in maintenance stage. And when he goes back to the previous pattern, it is relapse. As I mentioned, patient can go from one stage to another. It is not a linear cycle. It is a cyclic one. Patient can go from one stage to the other. For example, somebody who was telling, there is no problem. If he sees that there has been a cancer case in his family, he will suddenly go into action stage without you. Sometimes some women, when they are pregnant, they go from pre-contemplation to action directly. There are few who do not smoke over religious days. 8 days directly action stage, then back into pre-contemplation. So patients can shift from one stage to another stage anytime. From relapse, it can go back anywhere. So what we need to do, sometimes we need to give knowledge, but mainly we have to have those skills in order to change the attitude of the patient, that he can quit. So here in pre-contemplation, and contemplation, you just need to change their knowledge, which we have been doing by giving these awareness camps, etc. But that is not how the patient can go into this behavior change of being able to quit tobacco. What you need to do is actually an attitude change to instill that confidence in him that he can quit. Only then you can expect a behavior change. So until now, most of the actions that have been taken for helping people to quit is mostly change in knowledge. As I mentioned to you, when I passed out as an intern, all that I would tell the patient is that if you don't stop consuming tobacco, you will have cancer. Has anybody done that? That is how we have been trained. But that is not what is going to help for this person to come out of this mess. You need to instill confidence in him, motivate him that he can quit, and give him that expertise. Only then you can expect a behavior change. Not by giving information, education or advising, but by motivating. So like Krishna, he doesn't fight the battle himself. There is no need to fight with the patient. All that Krishna does is motivate somebody else and leading the team from behind, giving him the needed expertise and clarifying the doubts for him. So we have a small quiz on this until now.
Okay, after the quiz, we will have 15 minutes tea break. So first, start with tea at time, then tea at
So I'll pass you the link. So you added it? Yeah. So for this quiz, I will be sharing a link on the WhatsApp group where I have been added. Just click the link, add your name, and we'll start the quiz. It is a live quiz, each one has to take separately. It is timed. We'll take one question at a time. Everybody has the smartphone, right? So I can see 5-6 people who have joined. Are you being able to join? We'll start with the 5th question. I'll wait for a minute for everybody to join. Yeah? Okay. We'll start. Can you see the question? But you still can't see the question, right? We'll skip the quiz. I'll
It's not a this thing quiz, you can just read and ask them.
Okay. So I'll just read the question, few of them, and probably you can just give your opinion. कहाँ गया? हाँ. So in this stage you are not considering any behavioral change. Which stage? I will not give options. You are not considering any behavioral change. It is pre-contemplation. You don't realize that there is a problem, and hence you are not even considering that there is a need to change your behavior. Which of the following interventions would be least appropriate when working with someone who is in pre-contemplation stage? I will say the options for this. I will read the question again. Which of the following interventions are least appropriate for a patient in pre-contemplation stage? The options are giving them NRT, letting them know about the benefits of quitting, telling them the hazards of tobacco, and none of the above. NRT is correct. You cannot give them solutions because they are not aware of the problem only. Is anybody still attempting the quiz? Okay. Eighth question. Can you see the question? Okay. He is finally ready to quit, but he has not quit. He is in preparation stage. He is motivated enough to now quit, motivated to go into the action stage. 9 people have written maintenance. Kiska maintenance? Ninth question. What characterizes contemplation stage? The second stage. We'll take that photo right now.
You're going there.
No, I'm here. You take it from behind him.
Acha, acha, acha.
Admitting that there is a possibility that there is a problem, but the patient is not willing to change his behavior. Last question. I just smoke 7 to 8 cigarettes every day. The patient is not realizing the problem and hence he is in pre-contemplation stage. The 6 people who have written maintenance, who is maintaining himself or herself with 7-8 cigarettes? So, here the patient is not realizing the problem. I have the names who have written maintenance. So we'll see if my internet can pull up the result. Dr. Shweta? Great. So we'll go ahead. Wow! Many apparitions of the day. So coming to the main part of tobacco cessation therapies, the formula 80, 15 and 5. So cessation can either be by counseling or by pharmacological methods, and there are some new advancements which I will talk about. However, the main 3 components are counseling, NRT and pharmaceutical drugs. When it comes to counseling, or I would like to elaborate on the 80, 15 and 5 that I have written. For every patient that you deal with for tobacco cessation, 80% of your time or energy should be focused for counseling, 15% towards NRT and 5% towards pharmaceutical drugs. Also, the number of patients that you see for tobacco cessation, 80% of them will only need counseling. The other 15% will require NRT and only 5% will require the pharmaceutical drugs to quit. This highlights the importance of counseling for tobacco cessation. The amount of time and the amount of patients that you will be able to deal with counseling alone will be almost 80%. So before we go into counseling, there are certain things that you need to be clear about. Your attitude towards the disease, that it is actually a disease. Tobacco consumption or tobacco addiction is a disease, it is not a choice. The thing which started with peer pressure, that was the only time he or she made a choice. But later, how it gradually takes the patient towards addiction was never his choice. No one wanted to reach 10 cigarettes a day or 20 cigarettes a day. It is that pattern that kept trapping him into this cycle of taking so much. And hence your attitude towards that patient should be full of empathy, the way you would care for a patient who has got oral cancer. With that same empathy, you have to treat this patient. Also, decision making is always left to the client. Decision regarding how to quit, why to quit, how much to quit, when to quit. As I already mentioned twice, thrice, that tailor-made intervention, and these tailor making is mostly from the patient, not by you. You are only guiding them, motivating them. How to do it also the patient will tell you. You have to draw ideas and solutions from the patient. What will work when he has a craving? It does not have a standard formula. It is different for each patient. And hence, the responsibility of quitting should be on the patient. If you take the responsibility the day he goes into a slip or a relapse, you will start acting very aggressive. Arey, I had put so much of time into counseling you and you went back. That should not be your attitude. If the patient went in relapse, you know it is a part of the journey, and hence you will be calm and composed that I understand that you went into relapse. It is a very normal way people go into relapse, and I can still help you. We can again go and work it further. So that should be your attitude. Counseling techniques, before I tell you what to do, let's see what you don't have to do. Once you realize that it is a disease, it was not patient's choice to have 10 cigarettes. So now that you realize, you don't have to blame the patient. You don't have to instill guilt, instill fear. Don't have to argue with the patient. I told you now quit today, now means now. No. He says after 10 days because your formula is 10 cigarettes a day, but he says no, 15 days. Agree. He says I will do it on my birthday. Like birthdays. But you can give the best option that is scientifically correct, that it is better to have the quit date within 10 to 15 days. Obviously, if the birthday is 6 months away, you can't say okay birthday. But you have to keep tailoring it as per what the patient is agreeing. The patient is willing to work towards that. So don't be authoritative, as I already mentioned. As a dentist, we have a different kind of a prescriptive nature, that what I say is right. In this, it is not so. Whatever the patient says, you have to listen and make the plan. Don't be sarcastic or demoralize the patient. Now, what you have to do first is express empathy. Communicating with respect, with care, makes a whole lot of difference. There are more than 1200 research articles that show that empathy alone as a quality is enough to counsel the patient. Even if you are not a doctor, dentist, psychiatrist, psychologist or a counselor by profession, even a layman who is full of empathy can help someone quit or can help someone motivate. But that attitude has to be there to take care of the patient and not deal it as a, okay, tobacco is bad and yet you are having it. No, you know why is he having it. So empathy plays a very important role. Develop discrepancy, when develop discrepancy means that the patient will draw, from the patient you have to draw ideas, solutions, tailor-made intervention. Roll with resistance, you agree to whatever he says. Quit date 10 days away, okay 10 days, 15 days, okay 15 days. But yeah, beyond that, you have to explain him that it will not help you if you try to keep it so long. Support self-efficacy. Everybody's way of dealing, for example, withdrawal symptoms, somebody can bear the headache, somebody cannot. Somebody will go into relapse twice, thrice. Somebody will go into slip twice, thrice. Somebody will never go into any of these. Quit is quit forever. So respect everybody's capacity. The addictive power of nicotine on each of people is different. You remember in that slide where I have told in fetal growth, the number of nicotine receptors increase when parents have been smoking previously. The number of nicotine receptors are more, there is more release of dopamine, the patient feels more high, the patient will feel more low, withdrawal symptoms will be more exaggerated. So, for some people there might be no withdrawal symptom at all. For some people, we have seen there have been, we must be knowing at least one person who has quit tobacco only on the basis of his willpower. No counseling, no motivating, just one day he thought I will quit it, he has quit it. While somebody even after you counseling him 10 times might go back into relapse. So each and everybody is different. Don't try to compare or tell them that, oh, you couldn't do this. No, you know that the disease process is such. As I mentioned, high degree of empathy is the most important factor. Strategies for conveying empathy, there are few non-verbal ways, the voice tone, the facial expression, pause, eye contact, posture. You have to be welcoming. When he is talking about his whole big story of tobacco, how, why, you cannot be on WhatsApp or checking your Instagram stories. You have to listen, understand, because it is out of what he is talking, you are going to make the treatment plan. So the goal is that he should talk more, you should listen more, and out of that you should make the treatment plan. There are certain verbal ways, I will explain that a little in detail. Open and closed ended questions. Anybody knows what is open ended? So questions, an open ended question will help the patient to describe it as much as in detail. For example, for dental treatment, if you were to ask, are you having pain? The answer is yes or no. Did you come to know the details of the pain? No. But if you were to ask, how are you feeling, or can you describe your pain? Then he will tell you that there is pain on eating, there is pain on eating cold, or there is continuous pain, there is pain only in the lower jaw, etc., etc. So the more your questions are such that they are not judgmental, number one, or they help the patient to describe. Your questions should be prosed in such a way. Examples, don't you feel like quitting smoking is already a judgmental question. Trying to tell him that you should be quitting, right? Until now you have not quit. Instead, what you can ask is, what do you think about your tobacco use? When you ask such a question, he will probably tell you in detail why he started, what happened, how did he go from 3 to 10 cigarettes, did he try to quit, does he want to quit, does he feel bad about consuming or being in that addiction trap. He will try to be as elaborative as possible. Are you ready to quit hookah? Some people are saying yes. So instead you can ask, what do you think about setting a quit date? When you give them that option, rather than saying, let's quit on day 10. When you would hear this question, what do you think about setting a quit date? There is a higher possibility he will say, okay, let's do it. So this can make a difference when you are counseling or when you are motivating. Doesn't your wife get mad at you? You are having 20 cigarettes a day? This is a judgmental question, that the wife is bound to get mad at you, right? And she should get mad at you. Instead, you can ask is, what is your wife's reaction? What does your family feel about it? He might say, yeah, my wife doesn't like it. But when the question is, doesn't the wife get mad at you? How would you feel? So what is your wife's reaction? So he will then calmly confess to you, yeah, that my wife doesn't like it, that I smoke, we have kids, etc., etc. So asking open-ended questions, some of the formats are like this. What do you enjoy about your smoking? Is a good way to ask him that why is he still having 10 cigarettes? What about the tobacco that you don't like? You seem to have some concerns about your use. Tell me more about them. What concerns you about that? How do you feel about it? What would you like to do about it? And what do you know about it? So such questions help the patient to be, number one, comfortable talking to you. Because remember, these patients who are into 10 or 20 cigarettes are already helpless. They want to quit somewhere. They know it is going to cause cancer. It is hazardous. Most of them have tried in the past. Because of so much of awareness now, most of them have tried at some point or the other, but they have failed. And hence they are still consuming that poison which nobody would do ideally. So they are in that helplessness situation. Sometimes the wife is also nagging. He is feeling bad about it. He wants to quit but is not being able to quit. So these questions will make him feel comfortable that this particular health professional knows and understands me and my problem. And hence he will open out, listen to you with your answers. He will be more receptive towards your motivation. Some words of affirmation. Every time the patient comes, you have to appreciate him for at least one thing. It can be anything. Suppose it is the first consult and he says, now I smoke and I have kids, but I would want to quit. You can say you are a good father that you thought about it like this. When he came for a follow-up, he said, I tried to go from 10 to 8. It is good that you tried to taper it down. You can further do it in the same way. So this changes the mindset of the person. That must have been very difficult for you. Every time there is a withdrawal symptom, it has been difficult for him or her. That is a good suggestion. If he says, let me quit after 12 days, yeah, it's a good suggestion. Let's do it like that. I appreciate that you are willing to talk to me about it. Just willing to talk about it can also be appreciated. You really care about your children. It is great that you had quit smoking almost. If he has had a quit history, which failed later, and then you ask about it, he says, I had tried to quit, it happened for a week and then I went back to my pattern. So you should appreciate over that also, that you have that willpower to quit if you've been able to stay away for a week. So when it comes to tobacco de-addiction, what she mentioned that time, 5A and 5R approach. So when the patient wants to quit, when the patient agrees to quit, is motivated now to quit, you follow the 5A approach, which means you ask, assess, advise, assist and arrange. I'll take each of this in detail, but remember, when the patient agrees to quit, you have to follow this 5A pattern. When the patient doesn't agree to quit, he is in pre-contemplation stage, or he is in contemplation where he knows that there is a problem, but he says, no, I don't want to quit. What you follow is the 5R approach, in which you talk relevant benefits, relevant risks of the hazards, also the rewards of quitting. What are the roadblocks? Ask him, why do you disagree to quit? Ask about that and try to plan accordingly the talk. And repetition. Every time the patient comes to you for the root canal visit, tell him that, did you give it a thought? Would you like to quit? Did you consider thinking about it? Talk only one sentence every time and just keep repeating so it registers in his mind that there is a need to do so. Also end it on a note that, I agree, I understand that you don't want to quit now, but if at all in future you think you want to quit, I am always there to help you. This keeps the door open, because believe me, at some point or the other, the patient realizes he is getting trapped into that increased consumption and he will want to quit someday. If you have left him on this note, he will always come back to you. Also, you left him on a comfortable note by arguing, no, you should quit. You kept it very comfortable for him that it's okay, you don't want to quit, but whenever it occurs to you, the thought comes to you, you want to quit, I am there. So that is the 5R approach for patients who don't agree to quit. But when they agree to quit, what you do first is ask. Now ask is taking history. This is the most important thing in counseling. The more you ask, the more the patient talks, the more better you will be able to make a plan. What you will ask is, first of all, ask every patient for tobacco consumption, not only those patients on whom you see a stain. Ask every patient about their consumption, document it. Key questions to ask are obviously the history, frequency, type of the tobacco, quit history, reasons for using it, reasons for continuing. Have you tried to quit? If yes, how many days? How did you quit? If you had quit, did you have any withdrawal symptoms? Did you have any cravings? How did you manage them? Everything that is there in the history, you will ask them. So history of tobacco use, medical history as well. If there is any medical history, as small as I am a hypertensive patient, I take medicines for BP. Any and every disease on the earth can be linked to tobacco. We have many BP patients, most of Indians at elderly age. You can tell them once you quit smoking, you will surely be able to see a drop down in your BP. Measure it for them every time that they come, and there will surely be a difference. This alone, this activity alone can instill that confidence in the patient. Confidence for you as a healthcare professional, and confidence that yeah, he can quit, he should quit, his body will become better. Instead of just talking, doing the talk, you can make them do this activity. So take medical history and connect any and every disease that is there with the tobacco use. Quitting history, how did he quit, what were the problems. Family history, as I mentioned, then everybody in the family needs to be counseled, and passive smoking exposure as well. Then is the access. After ask, you have to assess. So this is the gold standard test for tobacco cessation. It is called the Fagerstrom test. You have to ask these questions, then mark the points for it, and then you sum it up. So the questions are: how soon after you wake up do you smoke? You see the minute, you ask them. Do you find it difficult to refrain from smoking in public places? Which cigarette would you hate most to give up? How many cigarettes do you smoke per day? Do you smoke more frequently in the first hours of waking? And do you smoke if you are so ill that you are in bed most of the day? So this is the standard test used all over the world to determine the severity of dependency on tobacco. So this is for smoking. So when you read these questions, can you find a pattern? There is one question being asked repeatedly in different ways. Anybody who can think of one question which is repeated, and why is it so? There is one thing which is being inferred from 3 questions. No, frequency is just asked once. How many cigarettes do you smoke per day? That is the frequency. Pattern of smoking, anything that you would like to add? Huh? We haven't asked the form of smoking. This is the test for smoking. The next is for smokeless tobacco. It is similar questions. I will take you there. So there are 3 questions which come to one inference. The whole test is on dependency. So if you see, no, we haven't. So I'll give you a hint. So question number 1, how soon after you wake up do you smoke? Question number 3, which cigarette would you hate most to give up? And do you smoke more frequently during the first hours after waking? Don't you think these 3 questions actually mean the same? This shows that the urge to smoke is highest in the morning. Why? Because the 8 hours that the patient slept, there was no nicotine reaching the brain, right? When he woke up, the stress levels are high, and hence smoking or giving up smoking the cigarette which are taken in the first few hours after waking up is really high. For patients who give you attitude, I will quit whenever I want, it is under my control. Right now I am okay. The day I get any such lesions or cancer, I will quit immediately, I can do it. Tell them to try and quit the first 3 smokes of the day. They are the most difficult ones. It is very difficult to refrain from that. Even patients who keep tapering from 10 to say 2, 3, the last one that they will do will be the morning ones. Because that time the urge, the stress levels are really high. Okay, so that high is the importance that they have put kind of the same questions thrice. So this is a standard test all over the world to determine the dependency. So when you score it up, when you sum it up, anything less than 4 is mild dependent, 4 to 6 is moderately dependent, and 7 to 10 is severely dependent person on tobacco. However, for the smokeless tobacco, what we call is modified Fagerstrom test, questions are more or less the same, but from a smokeless tobacco angle, the pouch or you add it up and the scoring is same, 1 to 4, 4 to 6, 7 to 10. So you will assess which stage the patient, not stage, how much is the dependency. Then you advise as to why to quit. Prepare him, motivate him, why to quit. Again, we have discussed these reasons. Reasons can be different for different people. For you and me, the medical reason might be at the top, but for everybody it might not be so. When you have been talking to the patient, you determine what is going to be the most relevant or the most beneficial form of reason to quit for him or her, and then you talk about it. You can sometimes fear approach, which we usually have been using. You will have cancer if you continue tobacco. That's the fear approach. Reward approach, you tell them about the benefits of quitting, like you tell about the BP, that your BP will keep lowering down once you quit tobacco. Family will be healthy, we have discussed this, life expectancy. You have to tell them 50% of the users will die early. That is the fact here. Quality of life will be better. Financial gain, for some people who are really underprivileged, for them if you count up how much they have been spending per month or per year, they'll realize how much they could have saved actually. Peaceful environment at home and probability of the child getting involved will be less. So that is how you first tell them the reasons. You have to give them reason to be motivated why they will quit or why they should quit. Then assist, how to quit. Again we have discussed this, the STAR formula, set a quit date, tell your friends and family about your decision, address to their cravings and withdrawal symptoms, and remove all the tobacco products from their environment. Very important, remove all the tobacco products from the environment. So that was assist them how to quit. Then you arrange a follow-up. Follow-up should be after 1 week, 2 weeks, 4 weeks, 1 month, then 3 months, 6 months, and then 1 year. Follow-up, sometimes I understand and agree patients don't turn up if you call them for a follow-up, but you can at least make a call and talk to them. Set additional follow-ups. Always tell them that if at all you go into a zone where you have very highest cravings or you have a new withdrawal symptom, feel free to call me and I will sort it out for you. Congratulate or appreciate the patient for whatever little small success that he has had. Arrange for quit lines. There are a lot of apps depending upon the age of the patient and how comfortable they are with apps. There are many apps that can be given to them which can act as an added reinforcing self-motivation. Help is obtained from those apps. And motivational messages. So trigger points, there are many simple things which can be done to avoid trigger points. There are few patients that will say, as soon as I wake up, I just want to smoke, because that has been their pattern everyday morning. For someone like you and me, every day as soon as we wake up, we would just go and brush our teeth, because that is our pattern since n number of years. For these patients, it is directly reaching out to the cigarette. So for that, you have to explain him how to now switch to going and brushing every day. If they keep themselves empty, idle that time, the brain will keep hitting the memory what to do in the morning that they have been doing till now. So trigger points are to be, some of them might have a trigger point, some might not have any. For example, if I pass, I have been listening from many patients, it sounds very silly to me. And when I pass through this panwala, I feel the urge to buy a cigarette. Don't go through that route. Take some other route. Can be done, right? Simple thing. But this all needs to be spoken with him or her and plan it for them. So trigger points can be anything. Some people prefer smoking after lunch, after dinner. They would just get down and smoke after meals. So you have to change their pattern over there. They don't get down. Just sit and read a book or something, depending upon whatever is comfortable for them. Cravings. As I mentioned to you previously, many patients can quit themselves also, have tried to quit themselves. The major difference where you as a healthcare professional can make a difference is attending to their craving and withdrawal symptoms. Now craving is a urge, temporary urge. Any craving is a temporary urge. Cravings don't long forever. It is only temporary. It stays, the craving stays for a maximum of 10 to 15 minutes only. And hence the tobacco intake can be delayed by, should be delayed by 20 to 30 minutes. Now before I actually talk to you about cravings for tobacco cessation, let me give you 2 examples to make you understand what is craving and how this is a temporary urge. So simple thing, suppose if you have the habit of having your lunch every day at 2 p.m. But today, because this lecture is on, I don't let you move from here till 4 p.m. Okay? 2 p.m. you all are very hungry. Were we to serve food, you all would have eaten wholeheartedly. Because you are hungry, you eat every day at that time. Now by the time, suppose you go back home, it is 6 p.m. Do you feel as hungry at 2 p.m. or at 6 p.m. as much as you were at 2 p.m.? No. What do we say? Bhook mar gayi. What happened? The food hasn't gone, but the craving has gone. Because the brain registers that craving only for a maximum of 20 minutes. Similar happens when you are used to having afternoon naps. Again, suppose 2 p.m. you sleep every day for an hour. today because you are attending this? You cannot. Although the subject is dry, I might be boring you. You will yawn. The max you can do here is yawn. And now in the entire day you are busy, you sleep directly at 10. Do you keep yawning till 10 p.m. from 2 p.m.? Do you feel as sleepy from 2 p.m. to 10 p.m.? No. In half an hour you are settled, maximum half an hour. So the craving for sleep that is there, it doesn't go on and on and on, maximum 15-20 minutes, after which the brain doesn't crave for that. Similar is the situation with tobacco. When the patient has that urge to now consume tobacco because he is feeling restless, because he is in that stage below the red line, he will have the urge, but only for 15-20 minutes. That craving will be there only for 15-20 minutes. If he can delay or if he can distract himself for that 15-20 minutes and not have the consumption of tobacco or smoke, he can keep skipping the entire tobacco consumption. Now how will he do that? So there are different ways how to fool the brain into managing the craving which is there for 15-20 minutes. The memory cycle of the brain, which I told you, is only for 15-20 minutes. Deep meditation helps a lot. It might be very undermined. We think, 10 deep breaths hone se thodi you will quit smoking. But research has proved taking 10 deep breaths every time, there is a switch. That dopamine high can also be, do you know the natural ways of dopamine release? Anybody? Yes? Exercise, very good.
When you're very thirsty and we go and drink water, certainly that the feeling of well-being that is
Exactly, that is my second point. Drink 2 glasses of water. Exercise, sports, achieving something which you have set a goal towards, all these things also give the dopamine high. So wherever the patient is in the world, he can do these 2 things immediately whenever he has a craving. First, take 10 deep breaths and then drink 2 glasses of water. What they can do is, now they have to delay the tobacco intake by 20 minutes, because in 20 minutes that urge, the craving will go, and hence what he has to do is he has to distract himself. Distraction for 20 minutes is a very easy job. How do you guys get distracted for 20 minutes? Instagram? Anything else? Reels, stories, shorts, Netflix, chit chat, very good. I would prefer calling a friend and chit chatting for 20 minutes. Novels, reading a book, correct? Listening to music, yes. So each patient will have their own way of managing this. When you talk to the patient about craving, you have to write down what will he or she do when there is a craving. I can't tell a 70-year-old to see Instagram reels. He might not know what is Instagram. For somebody who just doesn't like novels, I can't tell him or her to read novels. For the 70-year-old, I can tell him to listen to music. So you have to understand the patient and give them their ways of distracting themselves every time that they have a craving. Next is diet. Most of these patients have a very erratic diet where they usually, because it is an appetite suppressant, what they do, they usually have morning breakfast and then directly at night. In this way, the metabolism is affected, and the metabolism of nicotine as well. It stays in the blood for a longer period of time. And hence it is very important to put them to healthy diet, about which I don't need to tell what is healthy diet, but to put them in a good pattern of breakfast, lunch, snacks, dinner. And then last is discuss with the family and friends about withdrawal symptoms and drugs. Here drugs mean pharmaceutical drugs, which can be either NRT or other medicines, which I will talk about. However, in the first consult, when you talk to them about counseling, when you counsel them, you have to talk about craving and whatever is going to work. The deep meditation and drinking 2 glasses of water is compulsory for everybody. Then tell them that you have to keep delaying by every 20 minutes. Distraction, how will the coping strategy to distract themselves should be decided prior to quitting, so they know, because at that point of time when the urge is there, they will not be able to think. There is a high probability that they will go into relapse. But if it is pre-decided that what they are going to do, it will be easy for them to distract themselves. This is a 7D methodology given by WHO for tobacco cessation, a very standard treatment, and this is mainly to manage the cravings. Sometimes only managing cravings is the patient's problem. He is motivated to quit, he wants to quit, he has tried quitting once, but he cannot manage his craving. So sometimes just doing this exercise for them might be enough. But you will be doing it only if you are aware how to do it. So you will have to discuss this with the patient and find out what will work best for him to distract himself for 15 to 20 minutes. Explain to him that the craving will stay only for 15-20 minutes, it will go away then. The patient thinks the craving is now with him forever, he will stay in this restlessness stage. Tell him that you have to manage yourself only for 15 to 20 minutes. So that is cravings. The other problem that we need to address as professionals is withdrawal symptoms. Withdrawal symptoms can be anything from anxiety, irritability, difficulty in concentration, restlessness, tobacco cravings, GI problems, headaches and drowsiness. Again, depending upon what you think is commonly going to be there, you have to attend to it. Tell him when you get a withdrawal symptom, when you get an anxiety, what are you going to do. This all has to be pre-decided in the first visit itself. Otherwise, as I mentioned, the patient will think, oh my God, something wrong has gone with my body. What my dentist said was everything was wrong. It doesn't work for me, it doesn't work for my body, I cannot quit. And this will be a permanent belief in his mind forever. And hence you attend to withdrawal symptoms first. Withdrawal symptoms are at its peak in the first 1 week. So tell them that the withdrawal symptoms will be only there for a week. For a week you manage yourself. It starts going down in the second week, and by the fourth week they are absolutely zero. So it is mostly the first 1 week or 10 days, 7 to 10 days is what that anxiety will be there, and they have to manage themselves only for the 10 days. So once you tell them this, they know what is coming and they will be able to attend to it better. Already you will be giving them how to manage. Anybody questions till now? As I said, sometimes only managing cravings will help you to achieve, yes. See the Instagram story 10 times a day. Don't you do? Huh? If it is reading a book, read for 20 minutes, close the book. Again open it when you have a craving. Listening to music, listen to 5 songs. Go back to your work. Again when there is a craving, you again listen to music. Go for a walk if it is feasible. If it is in an environment where he is working, he cannot move out, you cannot give that option, but that can be used in the evening. Call a friend. How many friends you have? 10? Call everybody once a day, they will be more than happy. So, every time it might not be possible, but you have to, these are ways which can be repeated. And as I said, these cravings will stay gradually. As you keep giving the body less nicotine, the frequency will keep reducing. We are telling them to actually quit only 1 per day as per the formula that I gave. If 10 cigarettes he is having, give him 10 days, tell him every day quit 1. One craving happened only once, baki 9 times so you are managing. So what we tell the patient, you start quitting from the first only. Probably you can try and distract or delay the first, second, third, fourth and fifth. So the tapering from 10 to went directly to 5. So probably one thing might not work every time, 10 times a day as you are trying to mention, but you have to find different ways then. So give them 2-3 options depending upon, for example for you I can give you Insta stories, Reels, Netflix and much more. Calling a friend, really, but for somebody I might give only 2 options. Get them into some activity. For example, if it is a 70, 60-year-old female who is using mystery every day in the morning, probably only the morning time is what we have to manage. She can be told, do knitting or something like that, random thoughts. The more you talk to the patient, you will be able to understand what will work best for her. Okay. Thank you. Coming to NRTs. So, you told me that you prescribe NRTs, right? What are the instructions that you give when you prescribe NRT? You give gums? So while giving gums, do you give any instructions how to use it? No? Okay. So most of my patients that I told you have already tried to quit in the past. Okay. And many of them have used the gum as well. That much advanced the Google helps in treating patients. Okay. In fact, the panwala who sells tobacco or cigarettes also sells the nicotine gums. Many of them. Are you aware? They have that as well. Why would, from a marketing strategy point of view, why you think they are keeping those contradicting things in their shop? Do you think any marketing guy would do that? Demand? Okay. Okay. So let's understand that some patient has been using nicotine gums, but still they fail. Why? They are going to the same shop, very nice, it's a trigger factor for them, correct? Another thing, I will tell you my experience, 50% of the patients have already tried to quit in the past. They tell me, we use the gums as well, but it gives me headache, it gives me that vomiting sensation, it gives me nausea. This is because there is a particular way of using the gum. If you don't give those instructions, this is what happens. They also tell that it is a chewing gum. Nicotine gums are not chewing gums. They are not chewing gums, they are not supposed to be chewed upon. When they buy it from the panwala, they don't know the instruction how it is to be consumed. And hence they use it as a chewing gum and then they fail. So anyways, I will talk about it a little later, how it is to be taken. So as I mentioned to you that tobacco has 4,000 chemicals, 200 poisonous, 60 carcinogens, but only one nicotine ingredient causes the addiction. And hence we have to fool the brain only for that nicotine part. And hence in NRTs it is a low dose of nicotine which is tapered gradually and the dose is controlled. There are many patients who ask me, will I not get addicted to the NRT then? But here the dose is really very low. Even if the patient is having these gums or the patch for 3 months, 6 months, it is okay because the harmful products are gone, number one, and gradually it will keep, we are going to taper it down. And it happens, it is very easy to taper the NRTs. So, depending upon the speed at which it is delivered, there are long acting and short acting. For example, a cigarette takes 8 to 10 seconds for nicotine to reach the brain. In a similar fashion, depending upon the speed of delivery, nasal sprays, the nicotine reaches faster. In a patch, it reaches slow, delayed, but it is there for a longer period of time. For example, this blue graph shows is for the cigarette. In a very short time, the nicotine levels in the brain and in the plasma are reached immediately. However, in a patch, it takes a very slow route to reach the levels, but it goes longer. So, out of short acting and long acting NRT, depending upon the dependency, which test was used for dependency? Pegasus. So, depending upon the dependency, whether the test is shows a score of between 1 to 10, if the patient is mildly dependent, then you give a short acting NRT. If the patient is moderately addicted, then you give them short and long acting NRT combination, and in severe dependency you give long acting NRT and long acting pharmaceutical drugs. Now among the So among the short acting and long acting, the only long acting NRT is a patch. Remember it in the form when, how long does it stay with the patient? The patch stays for 24 hours on the patient's body, and hence it is a long acting NRT. Small doses are released over a period of 24 hours. The gums, out of all the short acting there are 4: lozenges, gums, inhalers and sprays. In India, the commonly prescribed is gum and lozenges. So ideally we have 3 options: patch as a long acting, and as a short acting we have lozenges and gums. Gums work better with smoking, lozenges work better with smokeless. So when I tell you short and long acting NRT, what would you give? Either a gum and patch or lozenge and patch, because long acting there is only one. So starting with patch, it comes in doses of 7, 14 and 20 milligrams. It is supposed to be applied for 24 hours. Preferably tell the patient to change after bath in the morning. However, if the patient in his first follow-up tells you he had sleep issues, then you tell the patient to remove the patch at night before sleeping. So in a follow-up it is important to us. He will not mention because he doesn't know that the patch is causing sleep disturbance. You know, so you will ask. So these are the things which you should be talking to him when you tell him, did you have any sleep issues in the week? And if he's had it, he'll be like, you are completely aware of this, of what is happening with the patch. That confidence in the doctor comes with these small minute things. So if the patient is having more than 10 cigarettes a day, or when it is moderate dependency, you have to give with the patch. You start usually with 21 milligrams for 2 weeks, then 14 milligrams for 2 weeks, then 7 milligrams for 2 weeks. This is mostly the standard dosage that we go. If the patient is moderately dependent, then you start with 14 milligrams for 2 weeks, and then 7 milligrams for 2 weeks. Application has to be on different parts every time. However, it is not supposed to be on the head or over the heart. Mainly it is supposed to be on the arms, on the chest or on the back. Every time tell the patient to change the location. So if he starts with the arms, suppose the right arm, then over the chest, then this arm, then the back, then again on the right arm. That is how it is supposed to be switched. So there are a few instructions, not on the head, not on the heart, usually on the upper body, only one at a time. Do not cut or anything. Patients tell, can I cut it into half and all, is not allowed. Switch locations and cannot be used for pregnant or lactating mothers. I will share few of these instructions which you can keep in mind. These are the same kind of instructions that we just spoke of. Coming to gums, usually available, rarely available in 1 milligram, it is usually available in 2 and 4 milligrams. It is not a chewing gum. Stop calling it as a chewing gum, because it is not supposed to be chewed. It is like a nicotine base or a nicotine patch which is supposed to be applied inside the mouth. The absorption is to the lining of the mouth, and correct gum usage is the most essential thing. Now how it is supposed to be used, the method is called as chew and pack method. First we will discuss the dosage. 2 milligrams when less than 20 cigarettes a day, 4 milligrams when more than 20 cigarettes, not more than 24 pieces a day. Length of the treatment can be as much as 2 to 3 months. Chew and pack is the usage. It also helps to keep the mouth busy for few patients who can give an answer telling, I want something in the mouth all the time to keep chewing, because that is what I have been doing with tobacco. So you can tell them to have the gum whenever they feel the urge to chew, that time only chew. So the correct way which you should be aware, which the pan wala doesn't tell, and hence the patient fails to, fails to quit or then considers that he cannot quit, is the method. What they are supposed to do, they are supposed to chew only for 2 to 3 times, or say maximum 5 times chew, and then park it between the buccal mucosa and the teeth. Only when there is a craving, bring it back between the teeth, chew only for 3 to 5 times and again park it. Or chew until there is a tingling taste or peppery taste that comes out of the gum, and then park it. If they have a craving, again bring it back. Now that can be in another 10 minutes or in another 20 minutes. But if they continuously chew, there is a release of lot of nicotine in a very short period of time, which goes to the brain in a short period of time, and hence then there is headache, nausea or vomiting. So this one line of instruction if you have not given and the patient ends up with headache and nausea upon quitting, what will he feel? That he cannot quit. It is not possible for him to quit. So just by giving the right and the wrong instruction can make so much of a difference. So every time you give the gum as a prescription, you have to explain this twice, thrice to the patient. Also tell him that if you keep chewing continuously, this is what will happen. Because inadvertently we have the habit of chewing the chewing gum, right? But this is not a chewing gum, this is a gum that is to be applied in the mouth, only to be chewed twice, thrice or 5 times, again park, again chew, again park. The correct method is called as chew and park. Similarly, lozenges, instruction with lozenges, do not chew, only suck upon it. Like that orange, yellow chocolates that come, the fruit flavored, you don't kind of chew upon it, you just let it suck upon it and it dissolves. This is what is supposed to be done with these as well. They also come in 2 to 4 milligrams, works really well with smokeless tobacco. If they chew or if they swallow lot of nicotine in a short period of time, same thing, headache, nausea, vomiting. Coming to inhalers, very rarely prescribed here in India. It is usually designed to imitate the act of smoking, because some patients they want something in the hand and keep puffing, because that is what is a psychological effect that the patient has. Those who smoke 20 cigarettes a day, the way somebody has that, okay, I want something to chew in the mouth continuously. Similarly, there are patients who say that, I keep having that urge that I want to puff. In those cases, inhalers are given. They usually have a cartridge. They have this holder with which there are these cartridges. You take the cartridge, put it in the holder and you hold it like a cigarette and you puff. So the psychological effect of puffing is also attended to, and the nicotine has also reached the brain and the patient is happy. And that is how he will gradually not smoke cigarettes, but get onto this, gradually you taper it and it will be good to go. So this is a systematic way of taking the patient down through tapering. Very rarely prescribed here, available only on Amazon, not usually in any shops. Gums and lozenges are freely available. Sprays, these are nasal, mouth sprays, not nasal sprays. You just spray it in the mouth, should not touch the lips. Do not swallow after a few seconds. Again, very rarely prescribed here in India. All these NRTs are obviously contraindicated in non-smokers. You don't prescribe them to somebody who is not into tobacco. Into heart patients and pregnant and lactating females, it should not be prescribed. Any questions on NRT? 2 important instructions. Anybody? When you are giving a lozenge, what will you instruct? Do not chew or swallow, only suck. And when you are prescribing a gum, chew and park. Explain in detail the chew and park method. So coming to pharmacotherapy, there are only 2 drugs which are prescribed for tobacco cessation. The purpose is to treat the nicotine dependence, usually the nicotine receptors that are there in the brain. Consider them as small holes. All of us have nicotine receptors in our brain. However, they are closed. They are holes which are closed. The moment you try experimenting, the first time that you smoke, you try e-cigarette, you try vapes, you try hookahs, these nicotine receptors open for the first time. Release of dopamine, feeling good, but if the nicotine receptors are open, it wants nicotine, right? It wants that release of dopamine, and hence the urge starts. So what does this drug do? It closes those doors which have opened, and hence the nicotine craving reduces. That is the pharmacological mechanism. So if the dosage is right, then nicotine withdrawal symptoms are not seen. The choice of medication, why somebody would prescribe drugs when we know counseling is the major method, NRTs are there to manage the craving, it depends upon the adverse effects. If some people, in spite of you giving correct instructions, is experiencing vomiting, nausea, or he has his previous belief that nicotine gums are not helpful, it causes me problems, and is not willing to try in spite of you teaching him the correct method, then you can go for pharmacotherapy. Adverse effects also those places where it is contraindicated. It is contraindicated in heart patients, pregnant and lactating. Sometimes people have this associated psychiatric morbidity, seizures or any other mental anxiety, depression, etc. Then you might consider giving this over NRTs. Concurrent medications, cost. As I mentioned, patch and gums can go as long as 3 to 6 months. The patient might not be able to afford. In these, this is a cost-effective method. The NRTs are a little expensive on a long-term basis. Patient's preference, placebo effect. मुझे कोई दवाई दो. Huh? In rural areas, they believe in that. Then you give this instead of that. NRT might seem to them as a chewing gum or a chocolate. So you give a medicine for that. So patient's preference, prescriber comfort. There are two schools of thoughts. There are mostly psychiatrists or psychologists who treat de-addiction with medicines rather than NRTs. Either because they've seen more success with it or they are more comfortable with it. In my practice, I believe in NRTs a lot. I rarely prescribe a patient until unless he is having 30 cigarettes a day and he is not being able to manage even with NRT. In my 4th visit, I would give the patient a very rarely. I am more comfortable with NRTs. So it's the prescriber's comfort depending upon his experience. If it gives you the confidence that the patient will be able to quit better with this, you prescribe this or NRTs are better. So pharmaceutical drugs, as I said, both of them, what will they do? They will close the nicotine receptors, so there is no craving for nicotine. The two drugs are bupropion and varenicline. Zyban and Wellbutrin are the brand names. However, which one you will prescribe when is very easy to determine. Number one, bupropion can be given when the patient has started to taper. So if the patient is going to quit in say another 10 days, but is still finding it difficult to taper as well, he is sure he is going to quit. So to keep gradually closing the nicotine receptors, bupropion can be given. By this I mean that in this case, in bupropion, the patient is still having tobacco, is still smoking. However, he has tapered or reduced it, but is still having it, you can still give bupropion. So there is both, tobacco also going and the medicine also going. However, in case of varenicline, you cannot do that. You can give only when the patient has quit. You can't give these both things together. So if the patient is in preparation stage or if he is tapering but is finding it difficult, then you give bupropion, or else if the patient has quit now, he has come to zero, he comes to you in the follow-up on the 4th day that I am finding it very difficult, I will not be able to stay in this quit zone. Then you give him varenicline. So quit date can be 7 to 14 days after starting. The dosage is 150 mg per day, increased by day 3 to 4 to twice a day. Continue for 7 to 12 weeks. However, if there is no significant improvement by 7th week, you discontinue. Side effects a little bit, like any pharmaceutical drugs. Contraindications are seizure disorders, eating disorder, electrolyte abnormalities. Monitor blood pressure. For varenicline, it reduces, sometimes the withdrawal symptoms are very difficult to manage. So there is one slight, another factor what you will consider. If the craving is more severe, you give bupropion. If the withdrawal symptom is more of a problematic, then you give varenicline. So this is the dosage for Champix or Chantix, which is varenicline. I will share this with you as well on the group. These are the different brand names of the NRTs and the price, the companies. I will share this as well. These are the recent advances. It has been approved by FDA in USA that this machine, which is called as deep transcranial magnetic stimulation, does give 80% success in tobacco cessation. What happens is they keep the patient here, place this bucket kind of thing which has like the rays in MRI. It has focused rays that go to a part of the brain where there are nicotine receptors, and it keeps closing the nicotine receptors. It has to be done almost for a very severely dependent patient. Around 15 to 18 cycles are required over a period of initially every day, then alternate day, then once in a week, etc. Each session takes 20 to 25 minutes, completely non-invasive. Only thing is that the patient feels the head a little warm at the end of 20 minutes. So this machine was previously used for mental health illness like depression, anxiety, some seizure disorders. It is now in research for Parkinson's and Alzheimer's disease. However, for tobacco, alcohol and cocaine de-addiction, it is being used since 2019. In India, there are 23 places where this has been installed and is being used very successfully. Among de-addiction, it has shown highest success rate for tobacco, then alcohol, then cocaine, 80% success rate. So because it has been only 3 to 4 years, there is not a long-term research study as to how is the relapse, how it goes. But until now, it has shown a fair good success. So do's and don'ts: tell the patient to stop alcohol as well. Alcohol thins down the mucosa, oral mucosa. The absorption of tobacco is double. So tell the patient to stop alcohol as well. Do not switch to areca nut. Many of the patients do that. Areca nut is equally carcinogenic. Take more citric food before and after NRT. It helps in better impact. Reduce caffeine to half. Drink lots of water. It immensely helps. Eat food regularly. So the take home message is that tobacco addiction is a disease. As a healthcare professional, you should be completely absorbed by this fact that the patient is diseased and you need to treat him or her with good amount of empathy. It is a complex, multifaceted, which involves the human brain, human nature, socio-economics, individual coping power and the addictive pattern of nicotine. Don't be judgmental, be empathetic. Any questions? From the experiences that you have, okay, wait.
I know everybody of you had Goku samosa, Goku cup. So you can wait for 15 more minutes just for question and answer session and few words from madam. That's it. Right?
So I can either take a case study or I can take a quiz or both. So we will start with the quiz. We will see if we have time for. I hope the quiz works fast. Then we can surely take up the case study.